Thank you very much. My pleasure to be with you in Calder meeting today with an important topic, systemic therapy of hepatocellular carcinoma in Africa. This is my disclosure, nothing to disclose. Sub-Saharan Africa continue to have 80% of the global hepatocellular carcinoma in patients. Hepatitis B infection is the main etiology, and the HIV increases the risk of developing HCC. Mortality closely parallels the incidence rate in Sub-Saharan Africa because of the high fatality rate. Hepatitis B is the main cause in 50 to 60% of the cases. Hepatitis C virus is important in North Africa, like in Egypt. More than 40% of hepatitis B virus related HCC developed in adults younger than 40 years. Hepatitis C related cases are in an older age, peak between 57 to 62 years. Here's the hepatocellular carcinoma as according to the tumor burden. We have 4 different stages from very early and early stage, intermediate stage, and advanced stage. Concerning the advanced stage of hepatocellular carcinoma, we mean multiple lesions with portal vein invasion or multiple lesions with extrahepatic metastases. According to the data from Egypt and from Africa, most of the cases coming, more than 40% coming in an advanced stage. And according to the guidelines of BCLC, the advanced stage with or without portal vein invasion with extrahepatic metastases, and the most important is we have to have a preserved liver function and a good performance status from 1 to 2. These patients are eligible for systemic therapy. There is a substantial progress in the systemic therapies in the past 5 years, with a marked increase in the overall survival and the quality of life of patients. The recently approved combination of atezolizumab and bezolizumab have more than doubled the life expectancy. Sorafenib and lenvatinib remain as the most effective single drug therapies. In case of progress to the single drug therapies, sorafenib or lenvatinib, other molecules like regorafenib, cabozantinib, and ramucirumab have also improved survival benefit. According to the mode of action, we have 3 main modes of action to the systemic therapies: the TKAs or the tyrosine kinase inhibitors and anti-VEGFR2, the immune checkpoint inhibitors. For the tyrosine kinase, we have including sorafenib, lenvatinib, regorafenib, cabozantinib, and ramucirumab. For the immune checkpoint inhibitors, we have 3 main categories: the anti-PD-1, anti-programmed cell death, one like Nivo or Pembro, or anti-PD-L1 like atezolizumab, anti-CTLA, anti-CTLA1 like Tremo or Epili, or anti-VEGF monoclonal antibodies like bevacizumab. Both atezolizumab and bevacizumab became the first line of treatment now. Here is the mode of action in details. The TKIs, the tyrosine kinase inhibitors, working either in the endothelial cells or in the tumor cells, blocking the important receptors like VEGFR1, 2, and 3, and also in the tumor cells, also blocking other important signaling pathways in the tumor cells, blocking the tumorigenesis. On the other hand, the immune checkpoints blocking are monoclonal antibodies that acting on the PD-1, PD-L1, and both together may act in a synchrony to increase the efficacy of their anti-tumor effect. And this is the rationale of the combined therapy. So this is the monoclonal antibody. The immune checkpoints are monoclonal antibody targeting the CTL1, PD-L1, PD-1. For the PD-L1 inhibitors, we have the example of atezolizumab. For PD-1, we have Nivo or Pembro. And for the anti-CTL1-4, we have Epi as an example. The story of the evolution of systemic therapy starts a long time ago, more than 10 years ago, by the evolution of sorafenib approved by the SHARP trial. And after 10 years, we got approved lenvatinib as a non-inferior according to the REFLECT study. And recently in 2020, we got approval of the new combination immunotherapy atezolizumab recently. On the other hand, these are for first-line therapies. For the second-line therapy, we got regorafenib in 2017, and then in 2019 we got two important molecules like cabozantinib and ramucirumab, approved both according to Celestial and REACH2 trials. Some important molecules in the red unfortunately got a negative phase 3 trial. So for treatment sequencing, the atezolizumab plus pembrolizumab will become the standard of care as first-line treatment. However, more than 20% of patients do not respond to atezo plus pevo, and the median progression-free survival is only 6.8 months, raising the need to define options for second-line treatment. And sorafenib, lenvatinib, all the mentioned molecules could be recommended as second-line treatment in most of the guidelines. However, minorities in ESMO authors in 2021 only recommend sorafenib and lenvatinib only as second-line therapy, and recommended regorafenib, cabozantinib, and ramucirumab as third-line treatment. So the strategy of systemic therapy before 2020, it was sorafenib and lenvatinib as first-line treatment. Regorafenib could be a second-line treatment, should be in those patients who are tolerant to sorafenib. The use of cabozantinib as second-line treatment, whatever the sorafenib tolerance, or third-line treatment following regorafenib. Ramucirumab can be considered if the patient is having alpha-fetoprotein more than 300 nanogram per ml. By now, after the introduction of the immune therapy, the atezolizumab, pembrolizumab became first-line treatment. And if there is a contraindication or whatever not available or whatever means, we come back to the sorafenib and lenvatinib as first-line treatment. Here is the algorithm by now. First-line treatment is atezolizumab, pembrolizumab. If there is no response, there is contraindication for whatever, not available or not affordable, we come back to the alternative first-line treatment, which is sorafenib or lenvatinib. If tolerability of sorafenib, we can go as a second-line treatment for regorafenib. If alpha-fetoprotein is more than 400 nanogram per ml, we can go for ramucirumab, and other third-line treatment like cabozantinib or other immune checkpoints inhibitor. Here's the summary of the clinical trial upon which all these molecules has got approved for the guidelines. The IMbrave 150 phase 3 trial for atezolizumab, pembrolizumab, atezolizumab plus pembrolizumab versus sorafenib, significant overall survival over sorafenib 19.2 over sorafenib 13.4, and there is a 34% reduction of the risk death. Again, for progression-free survival, also atezo-bevo is superior than sorafenib, 6.9 over 4 versus 4.3, and there is about 35% reduction of the risk of the disease progression or death. Again, also for the quality of life, time to disease deterioration, the combination therapy of atezo-bevo is superior over sorafenib, 11.2 months versus 3.6. Back to the famous SHARP trial for sorafenib, and the sorafenib showed some overall survival benefit over placebo, 10.7 versus 7.9 months. Also has been again validated in the Asian Pacific. Overall survival of sorafenib is 6.5 over placebo 4.2. The lenvatinib as first-line treatment, the REFLECT study, as a non-inferior to sorafenib, showed overall survival benefit 13.4 versus sorafenib 10.3. And resource study for regorafenib as a second-line treatment, overall survival benefit is 10.6 versus 7.8 for the placebo, and also progression-free survival benefit 3.1 over placebo 1.5. And also celestial study for the cabozantinib as second-line treatment, overall survival is 10.2 over the placebo is 8 months, and the progression-free survival also benefit 5.2 over 1.9 over the placebo. And ramucirumab for patients over having alpha-fetoprotein bond more than 400 nanogram per ml show overall survival of 12.9 months versus 8 months placebo, and also progression-free survival benefit 4.1 months over 1.7 months. Actually, few data coming from Africa about the systemic therapy. Only 3% of patients with HCC received any disease-specific treatment in tertiary care centers of sub-Saharan Africa. Sorafenib was used only in 1% of these cases, despite that more than 20% presenting in BCLC-C. Tertiary referral centers can provide care for few selected cases in sub-Saharan Africa who can afford it financially. So of the overall treatment rate for patients with HCC is probably much lower. In sub-Saharan Africa, evidence-based systemic therapy is generally available at a great cost and is affordable to a minority of patients. Most of them are not insured. In Egypt, most of the evidence-based systemic therapy are available, and the medical insurance offers them, but not all, therapy for free. In Tanzania, only 50% of systemic therapies were available, and more than 70% of patients did not receive adequate therapy. Can we use systemic therapy in the intermediate stage? As we know that TACE is the only guideline recommended for standard of care for the intermediate stage. However, after TACE therapy or unsuitable TACE cases, we can use sorafenib, lenvatinib, as they showed an overall benefit of the overall survival and benefit also of the progression-free survival. So according to the recently guidelines, the advanced stage of hepatocellular carcinoma, we have 3 different lines. The first line of therapy, which showed median overall survival about more than 17 months. Second line treatment from 13 to 15 months. Third line treatment from 8 to 12 months. For the future direction, we can use systemic therapy in different stages of HCC stages. For example, for the early stage as an adjuvant, for the intermediate stage in combination of TACE, and for the advanced cases, we have an ongoing clinical trial, combined clinical trial. The most important of them is the combination of atezolizumab plus cabozantinib versus sorafenib. It's the COSMIC 312 trial. Another important leap, 002 trial for the lenvatinib plus pembro in advanced cases versus lenvatinib. Also another important ongoing trial, Himalaya, phase 3 trial for durvalumab and durvalumab plus trelimab versus sorafenib, important clinical trial as well. All these are waiting for the final results. Again, checkmate 9DW for nivo plus ipi versus sorafenib. All these ongoing clinical trials are important, waiting for the final results. Also, the combined therapy with immune checkpoints with other modalities of treatment of HCC, like with resection, with radiofrequency, with TACE, with other multi-kinase inhibitor, with radiation, with cytotoxic agents, also immune therapy with another immune therapy. All these combined therapy are in a clinical trial now, and I believe it might improve the outcome of the HCC treatment. We don't have to forget that the the underlying disease, hepatitis C, B, or NASH, or the comorbidities like in diabetes, metabolic syndrome, and the esophageal varices as well. We have actually some challenges in the treatment of HCC in Africa. We have to put comprehensive strategy to decrease the incidence and improve detection and treatment. Hepatitis elimination, important in view of the WHO call, a clinical trial. Less than 1% of the HCC clinical trial take place in Africa. The availability and affordability of different systemic therapy are a great challenge in Africa. Also, we need to have an African guidelines for HCC. And finally, improving the outcome of HCC, it should be in a multidisciplinary approach. All disciplines, the hepatologist, oncologist, radiologist, interventional radiologist, surgeon, all together may go focus for the same patients, and all the data confirm that great outcome coming from the multidisciplinary approach for the treatment of HCC. And thank you very much.